So I decided to do a slightly different format than usual. So it'll be a mixture of cases and videos, although some of the cases could have videos. And this first case is very interesting, and this is an illustration. I'm going to ask everybody at some point to take your phones out also for this one, but you won't be voting, you'll be doing something else. So this is a man who I saw in the office. I actually discussed this ad hoc when I was in Israel a couple of months ago, and people liked it, so I thought I'd prepare it as a real case. And this is a patient who I saw, a patient of mine. He's an attorney in Philadelphia, a very nice man, who had 2 seizures in his life, one at age 56 and the other one at age 58. Tonic-clonic seizures, no warning, and they're the only seizures he had. After the second seizure, he came to see me. I placed him on levetiracetam, 500 milligrams twice per day, and he's been seizure-free now for nearly 8 years. It's like 7.5 years. He has no risk factors for epilepsy. He's an attorney, married, he drives a car. He lives in my neighborhood, which means that it's 2 or 3 miles to get to a bus or a train, and there are no sidewalks. So the car is important for us where we live. I wish we lived in Moscow, where you had excellent public transport, Allah, but that's not the case. His neurological exam is normal. His prior MRI and EEG were normal, and I have 2 or 3 EEGs on him. I just have 1 MRI, and he's been functioning well as an attorney. He's noticed no decline whatsoever since started. And now he came to me. It's been 7.5 years since he's been on medication. And I said to him, well, you haven't had any seizures for 7.5 years. You've only had 2 seizures in your life. Everything is normal. Do you want to keep taking it? And he said, that's funny. That's what I wanted to discuss with you. Do I need to stay on medication? So I put it to you. What should we advise him? And granted, we're going to have a discussion, and he will make the final decision. We present odds and like, but whenever we have discussions with patients, we tend to lean one way or another. They're not coming to us as neutral fora. They can go on the internet otherwise. They want to know what our advice is. Is there a meaningful chance? So what are the risks that we're going to tell him of having seizures if he relapses? And are we going to say we think it's a reasonable thing to try or not a reasonable thing to try? So Amos. And we need a mic for the audience, because otherwise I can't keep walking back and forth with my microphone.
So thank you. I think this is an everyday problem, and what I do is I discuss it with the patient, and it's up to him to make the decision. But I would strongly advise him against stopping. If it ain't broke, don't fix it. I tell them, and they say, okay, maybe reduce the dose a little bit, slowly. And I say, your car drives well with 4 wheels. Don't see if it drives as well with 3 or with 2. So go on with this. If there are no, I assume that there are no side effects, no adverse events from this. So it works well. Why change? What's the issue? Why should you consider reducing it?
Well, I'll give you one reason, and that is that there is some data saying that levetiracetam increases bone turnover, and he may be at increased risk for development of osteoporosis. That's one reason.
So if there is this, then we can treat this. So if you think that he's osteoporotic, let's give him what is given to osteoporotic people. But the chance that he will have another seizure will mean so much to him, because he will not be able to drive anymore. His career as an attorney will change. I think all his lifestyle or whatever he does will change so much. So I would strongly advise, I would leave it to him, but I would strongly advise him to continue taking the medication.
But what do we think the chances of him having another seizure are? That's what I'm after here.
10%.
10%. Okay. Martin.
I'll go for 80%, 90%.
Okay.
There's no reason to have a seizure in the first place. So, and he had 2 reasonably close together. People get older, their brain gets older, and, we often don't find a reason for elderly people having epilepsy and having seizures, but they respond very well to treatment. And I was going to say exactly the same thing. If it ain't broken, don't fix it. What you have to ask him is what happens if things go well what do you gain? What happens if things go badly? What do you lose? And he'll make the correct decision, even if he is only an attorney or a lawyer or whatever.
And I have to say, I say the exact same thing as you do, Amos. I say, if it ain't broke, don't fix it. The car analogy is great. I've not used that. I have a different analogy that I've used. But when he comes to me saying, well, I want to decide, what are my odds? So let's talk a little bit. There was a very nice paper published in Lancet Neurology a little under a year ago. I think it came out in May or June by Herm Lamberink. And it was a meta-analysis of published studies with all the weaknesses of meta-analysis and all the strengths of meta-analysis, but it's interesting. And he had 10 studies ultimately that he liked. This is a PhD student in the Netherlands, 1,769 patients, a median of 5.3 years follow-up with prospective, retrospective, and randomized study, a mixed bag of patients, which is always the problem. And this is the graph that he found, that you can see that when medication was withdrawn, there's a rapid drop. So the proportion of people remaining seizure-free early on drops quickly. And then the slope changes. And once you get out very far, it's pretty flat. But you can see that on average, about 60% remain seizure-free, or a little under 60%. So the relapse rate is not small. And then he came up with the factors that are, were significant. And this is a page from the paper which I would not encourage you to use. And I'm going to have you take your phones out for a minute. But for those of you who don't have cell phones, smartphones, what you can do is assign points based on that. So epilepsy duration before, these are factors that made a difference. Duration before remission. So in the case of my patient, he had it for 2 years before he went in remission. Seizure-free interval before withdrawal, my patient was about 7.5 years. Age of onset of seizures, and then you can look at what that is and you assign points, number of seizures before remission, febrile seizures, et cetera, and then you can come up with the total number of points, and that will estimate the relapse rate. Now, all of you take out your phones if you want, because I'll give you a site to put on your phone. So if you do a Google search on epilepsy prediction tools and search this, you can then go to your website. When it comes up on your phone, just in the upper right corner or upper left corner, depending upon whether you have Android or Apple, there are 3 dots. Hit Add to Home Screen. Okay, and just do a Google search on epilepsy prediction tools. What it will do is it will put this website on your home screen. Okay, so I'm on this. Okay, so I think I'm here now. Okay, so let's go through it, because what I want to do is show you what happens. So duration of epilepsy before remission. So in the case of this patient, it's 7 years, right? I'm sorry, rather it's 2 years, right? And then we have time since the last seizure is 7 years, correct? Okay. Number of drugs, he has had 1. Age of onset of epilepsy, he was 57. And then he is male. There is no family history of epilepsy, so that's negative. No febrile seizure. Total number of seizures, he had 2, so that's 0 to 9. Self-limiting epilepsy syndrome, no. Developmental delay, no. Focal seizures, probably yes in his case with onset at 57. EEG, I don't have one recently, but prior ones, several were normal. And then you hit calculate. I do this and I do it right on my phone in the office with patients. And what you can see is it then gives you very nicely 2-year seizure recurrence risk, 46%, 5-year recurrence risk, 57%. Now, a 10-year chance of being seizure-free for 1 year is 98%, but that doesn't matter. So it was interesting that Amos estimated a 10%, Martin estimated an 80%. What this estimates is a 46% chance. Okay, right? So if we go back and modify things somewhat, what we can see is duration of epilepsy before remission. The only factor that will make a difference is time since last seizure. So if I increase this to 20 years, for example, number of drugs is 1, age of onset is still going to be 57, sex is male, negative, history of febrile seizures, self-limiting syndrome, no, developmental delay, focal is yes, EEG normal. This is the only variable that seems to make a difference is this, the duration. The others, I've played with it before, it gives the same, it drops his odds down to 18%. So what I can do in the office quickly, and it takes about 20 seconds, far less time than it takes to get this computer screen up on that screen, is show the patient the percent and say, these are your odds. And if it were I don't want a 1 in 5 chance or a 1 in 3 chance or even a 1 in 10 chance of having a seizure. And I think that, if it were I would probably stay on drug. But now here is a number that you can use. And it's actually a very practical tool. And I show this to patients and they like it. The question is, if the person relapses, what happens? What do you advise? So we'll come to this now. So the second part of this case, since the first part was painful, I don't have to go on the internet anymore. But what would you tell him? Let's say he's said, against our advice, that he hates the idea of taking medication. It bothers him. He wants to try going off. He thinks a 46% chance is a good chance. The glass is half full rather than half empty. So what would you tell him to do about driving? So how many people in the room would say, you must stop driving during taper or after taper? Okay. So many of you would say, don't drive. And that's a way of saying to him, you are staying on your drug, because most patients, if told they have to stop driving, will not stop. So, and this is interesting. So when you look at what the risk of seizure is after 12 months after withdrawal, and this is a paper by Bonnet and JNNP in 2011, you can see of 317 patients, none at the moment of withdrawal had seizures, but within 3 months, 64 had had a seizure. But after that point, so the probability of recurrence in the next 12 months, once they'd gone that, is only 15%. If they'd gone 6 months without a seizure, it's 9%, and then it doesn't drop very much. So the odds of a relapse are 30% on average in this series. And again, using our calculator, which you now have the option of having on your home screen, it may be even higher in his case, 46%. But if he wants to drive, the odds of recurrence are not tiny. Although if he lived in the UK would say with a less than 20% chance of a relapse in the next 6 months, it's okay to drive. Or in the next year, I should say, at the UK. It's okay. So the UK would say, if you're coming off medicine and your odds are higher than 20%, you can't drive. If it's less than 20%, you can. And that would tell us, by UK rules, we should probably not have him drive for 3 months. Okay? Now, no other country, as I can tell, is actually as scientific, and that's the NICE guidelines. Right, so the UK, and we're going to come to that in a minute when you come back. Now, the interesting thing, and I couldn't find recent data on the U.S. Highway Administration, the Federal Highway Administration of the United States government. It doesn't publish this data that frequently. But they showed what the risk of, how much people drive. And you can see here that the average American, at least, most trips are short. They're less than 1 to 9 miles, so that's, 1.5 to about 14 kilometers. That's about 2/3 of trips. And then another 16% of trips are still less than 12 kilometers. So less than 12 kilometers, rather 25 kilometers, or 30 kilometers rather here. Most trips are relatively short, and only a small portion of trips are that. And then you could look at a non-appropriate way of doing it, but I can put a calculation out there that if somebody spends half an hour a day driving, so you could actually and you're saying don't drive because there's a 20% chance of relapse, and I'm going to say that's not an intelligent way of viewing it. I think what you want to do is look at the risk of accident. So if someone spends half an hour a day driving, which is 2% of a day, and the risk of seizure is 15% in a fixed period of time, the risk of having a seizure while driving is 0.3%. Or if you spend an hour a day driving, 0.6%. So the odds of having a seizure are well under 1%, and in fact it changes, because in the first month, as you see, or two, the odds are higher than farther out. Now, the interesting thing in the US, at least, is that there are 6.3 million motor vehicle accidents per year. Okay, and that's recent data. That's about 2 years ago. So over 6 million accidents in the United States, and this is before Uber and the others have self-driving cars. The average risk, when you look at the number of drivers, is about 200 and some million licensed drivers, is about a 3% risk of an accident per year for every licensed driver, because there are 218 million drivers. But in fact, a lot of these people don't drive or hardly drive at all, so the risk for regular drivers is probably higher. A lot of older people have licenses but are no longer driving. If you live in Manhattan, in big cities, you probably hardly ever drive a car, but you may have a license. So the risk is probably higher. So if there's a 3 to 4% risk of having an accident in any 1 year, and the person with epilepsy has a 0.3 or even 0.6% risk of having an accident while having a seizure while driving and then having an accident, that's actually pretty small. It's a relatively small incremental risk. And then if you look at the scary figure, for a first-year driver, so that 16 or 17-year-old child of yours who you just got a license, the risk of an accident is 43% in the first year, and it's 37% in the second year. So why do you deny your patient with epilepsy who has a 0.3 or 0.6% or a 1% chance of having an accident, but you let your 17-year-old drive, right? Who has a much higher chance? Bill.
But what about the severity of the accidents?
That's exactly right.
So what about the severity of the accidents?
So this makes a difference too.
Yeah. So, I mean, somebody who has a seizure while driving may be having a different order of accident than a kid who's backing out of the driveway or in the parking lot. I don't know. I'm just asking.
Yeah, I mean, the kid who has an accident, these are reportable accidents. So this is not backing out of the driveway. This is, yeah. But when you look at
It might be insurance data, which it would be.
Yeah, I mean, they're insurance data. But in fact, there are measurable, significant number of deaths due to teenagers who die in accidents, and thousands of people injured per year. So all I'm pointing out is the illogicality that we're looking at the risk of seizure relapse rather than the risk of accident. And do we properly assess risk? I think the answer is no. It should really be for accident, not for seizure, not the probability of seizure. And then is there a risk to long-term drug use? Yes, there's some, bone health, cardiovascular, cognitive, and other. And we have to weigh the risk for person, but for society. There's the innocent pedestrian, the other driver. And people with epilepsy should be held to comparable risk, perhaps as other conditions like being a teenager or having Parkinson's disease or Alzheimer's. And again, we can't estimate risk, but how much is tolerable? So in the United States, a country where there's easy data for me to get, we have 35,000 deaths per year from motor vehicle accidents. Now that's smaller than our number of deaths from gun. We had 50,000 deaths from guns last year, mostly suicides. Okay, but 35,000 deaths and 2.5 million injured from motor vehicle accidents. So the incremental risk from seizure is actually very small. And then here's the other issue, as Martin said, jumped me ahead a little bit. If the person is taken off drug and has a seizure, what's the probability of a relapse in the next year? Well, in fact, the relapse, and this is from the Bonnet paper in JNNP, is 45%. So even though these people were seizure-free for an extended period of time, 45% relapse in that first year. So to say, which in the United States, virtually every government authority does, if you have a doctor-prescribed change in medicine and have a seizure, then you don't lose your license. These are exactly the people perhaps who we should take the license away from, except, again, how much do they drive? And how fast do they drive, and where do they drive? Martin?
People with diabetes, they don't have hypos. Why don't we take them off the insulin? Because their glucose is fine. The whole point is that the medication we give to our patients stop the seizures. That's why they're seizure-free.
Yeah.
So why stop them?
Right, yeah. So there are lots of things to consider. What I generally do is I say if it ain't broke, don't fix it. In general, by and large, I tend to be very conservative. I advise people to stay on medicine for a very long time. After 20 or 30 years, I often say to somebody, well, you're now 65, I'd hate for me to be sitting in my office at 90 and you're 90 and we're still discussing should you be driving. But at that point, if you're 90, probably you shouldn't anyway. But what I generally do, if people want to come off of drug, is I will tell them I think it's okay to drive. I would try to limit it as much as possible, certainly below an hour a day, no high-speed driving. If there's another licensed driver in the vehicle, let that person drive. Combined trips, don't drive to the supermarket one day and then to the drugstore the next day and then to the movies the next, but try to combine trips. Use public transport when you can. Avoid driving at times of day. If you know my seizures always happen in the afternoon, don't drive in the afternoon.
Just leave them alone and let them get on with their life.
Yeah, let them get on with their life.
So you get paid for this. I know
Yeah.
that. That's why you see them every 5 days or 10 days or 2 months or 3 months. Because you guys get money.
No, we don't. We're on-
we don't get money. They're just
Actually,
on
I'm
the
on
waiting
salary
list.
too. It makes no difference to me. In fact, if they come off, it's a bigger problem.
Yeah, but why
And
don't we
then-
treat these people like we treat people with diabetes, with asthma, and we're treating the symptoms that they don't have them, so the treatment works. Why on earth do we even have this discussion? It should be in our literature to say if you're seizure-free, you have no side effects, you're doing well, and you've got epilepsy, particularly if you've got good imaging and whatever, leave it alone.
So this is the argument for somebody to put a good article out there, which I can think of a journal that would happily accept it, on the lack of wisdom of tapering medicine sometimes. But I think if you are tapering it, there are some common things to do. But this is a common problem. We did a survey. We have a study that we did in which we surveyed a lot of doctors in the US, and about half of them tell people to stop, most of them tell them to stop driving for a period of time. Almost?
Another issue is the risk to the physician, to the neurologist. So what if you advise him, okay, you can do whatever you want. Really, the chances are 1% or 10% or 50%. I mean, I'm not going to tell you what to do. You can do whatever you want. And then they have an accident.
Yeah.
And then you are being sued.
Yeah.
So what are the risks? I mean, this should be an issue.
I mean, these are all difficult issues, and I think, the notion of disclosure, discussion, you want to document things to protect yourselves, but you're never perfectly protected. I've had 3 patients kill other people having a seizure while driving. On drug. Seizure-free for many years, and then had a relapse in one case, and in another case, seizure-free for about 1.5 years. So it's a problem. So I want to move to other things. In this case, it shouldn't last forever, but I thought there were 2 relevant teaching issues. One is the risk of relapse, and to show you a website that you can go to easily, and this thought about driving. And it's interesting that some of the experienced people in the room tend to be conservative. I must say, in my practice, the older I get, the more conservative I am in that. When I was younger, I was much more aggressive, and I see that in my practice. And then when you get really old, like Martin, you become incredibly conservative.
You're lucky you'll get old like
Yes. Fortunately, wisdom occasionally comes with age. Unfortunately, usually not. Okay, now I'm going to shift gears briefly. I'm going to show you some videos. I want you to tell me whether you think these are, and then we'll do some more cases. Is this epilepsy is the question? And if it is epilepsy, where do you think it's coming from? Is it generalized or focal, and if focal, where? So this is the first one. A very nice young man who's having his neuropsychological
now I'm going to
testing.
read you some problems. I want you to listen carefully. You can only ask me to repeat.
Good. We're 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 good. They're good. They're
Good
good.
job. All right. Stay there. Here, you sit down. You sit down for me. You're such a gentleman. You're so good. Coderwood is dynamite.
That was it. He's good. You're good because he says we're good. What is this? Is this epileptic? Is this not? What's that? What's that? Rejoice. What's that? He was saying we're good. We're good. No, we're good. Close. Both involve happiness.
So what's the history? I mean,
You can't know.
you can't.
The family comes in and just holds, what they do now, they just hand me the phone. This is what he does.
This is what he does every time?
He does this. Yeah, this is what he does every
That's
time.
an important
Yeah,
issue.
yeah.
If it's,
But please let me play the game my way. Yes, but this is what he does each time. So how many think that this is psychogenic? So we have a few hands say it's psychogenic. And how many think it's epileptic? Yeah. Okay. So this, we monitored him. This is absolutely epileptic. He has a corresponding, and it's stereotyped. Stereotyped every time. And his history is it came out of the blue. He had a normal MRI scan, just so you know. But he has an EEG abnormality, and during this event, the EEG shows an epileptic discharge. So where does it come from? You're saying frontal lobe. Which frontal lobe? What's that? Left? So how many think left frontal lobe? Raise your hands. And then how many think non-dominant temporal lobe? Frontal lobe, rather? Most say non-dominant. Why non-dominant? Because of speech. Okay, so this is especially interesting because this is dominant frontal lobe. This is dominant dorsolateral frontal lobe involving orbitofrontal and dorsolateral cortex. So this is very interesting. This is an automatism, just like wiggling the hands or smacking the lips. It's a vocal automatism, but it's generated from the dominant frontal lobe. Testing afterwards, he's aphasic, but he has a vocal automatism. So the fact that people speak during seizure doesn't mean that it's non-dominant. If it was meaningful speech at the start, it might be non-dominant. Probably is. But you can have a vocal automatism from the dominant frontal lobe. And we operated on him and he's seizure-free, so the localization is confirmed. Okay, here's another one. This person has a history. I'll give almost a brief history because he wants it. Okay, so just a brief history. A young man in his mid-20s with these violent episodes and a history of major depression twice with one suicide attempt. Spare you that. And he was given an anti-epileptic drug with no response whatsoever. These occur while awake, and it happens a few times a month at the very least. Sometimes he can go for several days in a row with one every day. I'm going to jump ahead a tiny bit. I jumped ahead too far. Still too far, we'll go back. He just holds his arms like that, and when his mother talks to him, he won't answer her. He just won't speak to her during this. Nurse is coming in on the right. Not getting too close.
Hi.
Okay, so that was it. How many think that this is not epileptic? 1, 2, 3, 4. A couple of others in the back. How many think it's epileptic? Okay, so a majority of people think this is epileptic, and some have no opinion, plainly. Okay, why do you think it's not epileptic? Victoria? You don't think this is epilepsy, right?
The movements were not stereotyped. They were very, very confusing. And the beginning of the seizure was a little bit atypical. She had a sort of, yeah.
And then, Manjari, you held the opposite opinion?
It's fairly typical of frontal lobe seizure. First, he has a kind of posturing with the right hand, followed by bicycling movements, followed by a gyratory turn to the left. And if all the episodes are the same, they're likely frontal.
Yeah, there's a complex, and then there's one other thing that's very helpful in this.
Michael, you told us this is it, but that's not true. There was something that happened later on. So I think it would be very helpful if we knew whether following this episode he was completely awake or whether he was confused for a while.
He's confused for a while after. Right.
He was confused, for a while. So I think this helps tilt the balance in favor of seizure.
And let me show you one other thing. When he goes forward, watch his head now. It's tough to see his eyes, but you'll see he has bursts of head movement to the right. And the left arm is dystonically postured. Got that dystonic posturing. Yeah. So this is plainly epileptic as well. We monitored him, no doubt it's epileptic. And again, sometimes is he confused afterwards? He seems confused, but again, he could be just refusing to cooperate. It can be a little tricky. But this hypermotor, violent reaction, but also that dystonic posturing of the left arm is a sign when you look at it that that's epileptic. That's a good objective sign, the dystonic posturing and his eyes and head turning actually opposite the dystonic side. Okay, so where is it coming from? Which lobe? So we think it's frontal, and which side is it? So it's actually left frontal again. So the head driven to the right, and it's interesting he has dystonic posturing ipsilaterally.
He doesn't have a optic aura?
No, he has no aura.
Because it could be also occipital, with first signs from the frontal lobe. When he starts with touching his eyes, the question is whether he doesn't have some feeling in the eyes that...
He never described a feeling in eyes, and I have to say...
But he has amnesia already.
Yeah, and I have to say, I guess we diagnosed him as left frontal, but we operated on him and he still has seizures afterwards, even though we localized him. So maybe our localization is wrong within that hemisphere, but it was clearly left hemisphere. Here's another one.
I don't know.
Okay, so what was that? Is that epileptic or not? All those who think it's epileptic, raise your hands. All those who think it's not epileptic? We have a lot of people who think it's not epileptic. So what you see, assuming I can get the mouse here, so watch it again, and notice the proximal movement that you see here. His earliest movements are axial and proximal, except for the hand patting.
I don't know. Good word, banana. Can you please give their butt? Can you help?
We train our nurses to step in front of the camera.
Where is it at? The one curly one.
Okay. And then with testing, he seems somewhat confused. So this is also epileptic.
It is from cingulate.
What's that?
Cingulate?
Cingulate. Which side first?
I'm
Right?
not sure. With cingulate, I'm never sure.
Yeah, I think it's hard to know which side. So the key thing is that early proximal movement that you see. So, and why did you say cingulate?
Because pseudo-purposeful movements with hand, automatism, and sign of gendarme looking at mouth.
Yes. Amos, you're trying to say something? Amos, did you have a comment? Or? Yeah, he had some left-hand automatism. Right. Yeah, so although a left-hand automatism could be ipsilateral, but then right after that left-hand automatism, you get proximal movement, which shows supplementary motor spread. And Yvonne is exactly right that it was cingulate spreading to supplementary motor, and in his case, it was non-dominant onset. But I don't know that we could be sure about the location. Now that, in contrast to this, but again, that type of movement and that vocalization in the previous one, that's epileptic. He's in the seizure now, assuming it's epileptic or not. at his right arm.
Where's your belt? Stay in the chair. Gotta stay in the chair, okay? No, stay in the chair. Stay in the chair.
He's following the command. Though he's not speaking at
Clap
all.
your hands for me. What's your name? Can you stick out your tongue? How many fingers am I holding up? 4. Good. Where are you? Can you clap your hands? I just heard this crazy.
So he answered 4. He could not follow the command. So is this epileptic or not? Again, first question. Could this be psychogenic? Do you want to see it again to start? Or? Okay? Okay. You've seen it. So is this epileptic? Yes or no? How many think it's epileptic? Okay. And how many think it's not epileptic? It's a lot of people. Okay. So again, it's hard to know for sure looking at it, but in fact, he's postictal, he's not speaking, and when we look at what he does early on, hands and the feet, right, and then he's got some dystonic posturing of that of the right arm.
Your belt.
See, so that right arm is down. So that's the clue that it's epileptic. That's the clue that it's epileptic. So what's the localization? Yvonne, if I can put you on the spot. What's that? Insula. Okay. So he has a cortical dysplasia in the left superior temporal gyrus extending back about 2.5 centimeters from the temporal pole. So it's a temporal lobe focus with spread. And one of the clues is that a lot of his movement is distal rather than proximal early on. He has distal hand and distal foot movement. And then he goes to that more cycling type movement. But that distal rather than the proximal movement suggests that it may not be quite so frontal early on. And that dystonic posturing is a clue that this is likely epileptic. So when you... Yeah, the dystonia was right hand, and his seizure is left. His focus is left temporal, left superior temporal gyrus. And we operated on him and the seizure stopped. No aura. He just does that. Okay, so that was a few videos. We'll go to a case. 19-year-old man with symptoms starting at age 13. He has occasional myoclonus of the arms in the morning, which, of course, nobody noticed for the first year until he was 14 and he had a tonic-clonic seizure. And then no treatment was offered. How many child neurologists in the room? I heard Hadassah's voice. Is that you, Hadassah, there? Yeah, okay. Would you treat him? History of myoclonus and 1 tonic-clonic seizure? You would. Why? Where's the microphone? Can you pass the microphone? So your rationale for recommending treatment is what?
The risk of recurrency, mainly.
What's his risk of recurrence?
Well, I cannot calculate according to your table, but I assume it's more than 50%.
I mean, this is juvenile myoclonic epilepsy,
Right.
right? He has myoclonus, tonic-clonic seizure. His probability of another one is probably above 70%.
Right.
So we might recommend. If he were a young girl instead of a young man, would that change your recommendation?
I would start another thing.
You would still start. Still start. Okay, so you would not discriminate against her. Okay, and in fact, no treatment was offered to him. And then at age 14 and a half, he had a second seizure, and then levetiracetam was prescribed, 1,000 milligrams a day. His EEG showed generalized 4 hertz spike wave, and then he had a recurrent seizure 7 months later, so the levetiracetam dose was doubled to 2,000 milligrams a day. And then he had another seizure about a year and a half later, or a year later, I guess, at age 16. And then lamotrigine was added to the levetiracetam, and then he had 2 seizures at age 17, whereupon he was switched from lamotrigine to topiramate, along with the levetiracetam. So now he's on 200 of topiramate a day plus levetiracetam. 5 months later, after he's placed on topiramate and the lamotrigine was stopped with levetiracetam, he has another seizure, tonic-clonic. He's still having occasional myoclonus. And then the topiramate dose is raised to 300 milligrams a day, along with levetiracetam, 2,000 still. And now he's tired, has poor memory, and he's irritable, though he does not have any migraines. All of his seizures happen in the morning within an hour of waking, and typically he knows when it's going to happen because he has myoclonus that morning for 15 or 20 minutes before he has the tonic-clonic seizure. Other days he'll get a jerk or two. That morning he has quite a few myoclonic jerks. So now what are you going to recommend for therapy for this young man?
Valproate.
So you want to put him on valproate? Okay. So valproate was substituted. This is in Professor Brody's clinic. Substituted for topiramate. He remains on the levetiracetam, 2,000 milligrams per day. His level is 68, and he has a seizure 4 months later. So since he's in your clinic, Martin, now how are you going to treat him? What are you going to advise?
Increase valproic and stop levetiracetam.
He's on valproate 500 twice daily with a level of 68, along with the levetiracetam 2,000 a day. What's that? I can't hear you. Can you pass the mic?
500 in the morning. 500 in the morning and a gram at night.
So 500 in the morning and a gram
Everybody
at night.
would do that.
Anybody else? We're all in agreement. Okay. So he was tapered off of levetiracetam, remained on valproate 500 twice a day, had a recurrent seizure, and then he was switched to actually 1,500 at night. This is when he came under my care, and I said, let's give it all at night. Your seizures all happening in the morning. And he had a good high level in the upper 80s at that point in the morning, and he still had another tonic-clonic seizure 2 months later. Again, preceded by myoclonus for 15 minutes, as usual. So now what do we advise? How are we going to treat him? What's that? Oh, he has jerks of his one arm or both arms. It can be bilateral, and sometimes it can be his whole body. In fact, in the 5 minutes preceding the seizure, it may be whole body myoclonus. He can even fall from the myoclonus of standing. So we could, add clonazepam when? What's that?
Yeah. I wouldn't give clonazepam to a young guy with GME, with impulsivity and the like. You know, I'd probably try zonisamide if he's still jerking.
Yeah.
I would try.
So we have a few options. We could add clonazepam, and I would say you could give it to him at bedtime. Some people have done that, but again, there are issues. You could add another anti-epileptic drug to valproate, although again he had seizures with levetiracetam with it already. We could use a rescue benzodiazepine in the morning. This is something that I've tried in a number of patients. If they have a good warning for 15 or 20 minutes in advance, it's a good trick. It sometimes works.
Zonisamide is very good for jerks, and sometimes the jerks sort of bring in the tonic-clonic seizure. You stop the jerks, they don't go to tonic-clonic
Yes, and that's
seizure.
exactly what happens with this guy. So I've done this in a number of patients, and you can either give them an oral benzodiazepine, you can give them a buccal midazolam, intranasal midazolam, or rectal diazepam, which seems rather aggressive, but one could try that and attempt to abort it. Or one could consider vagus nerve stimulation, or I suppose at this point you could think about an anterior corpus callosotomy. This is our range of options.
Why not zonisamide? You're not hearing me.
Okay, so you would add zonisamide to the valproate?
Yeah.
Okay, so we have one person adding clonazepam.
I'm worried about this myoclonus story. Because we have to probably know, which is bizarre, to having a series, 15 minutes of myoclonic jerks before preceding a seizure. And there's an entity, it is a cortical myoclonus that responds to piracetam, to high dosage of piracetam, 10 grams of piracetam, 15 grams. So I would try that, seeing that we will not suppress the myoclonus if the myoclonus precede always the trigger the seizure. I will try to stop the myoclonus.
Okay.
You could have a progressive myoclonic epilepsy.
So Fycompa would be another drug that could be tried. It's been shown to have some efficacy in generalized epilepsy. He could have certainly bedtime Fycompa. He won't have the dizziness and presumably have a good level in the morning. That would be another treatment option.
Just one sentence to myoclonus. I would make the back averaging myoclonus EEG to see whether this is a cortical one preceded by some spike in the EEG, some hidden spike.
So we have done monitoring on him. We've sent him for ambulatory. The trouble is his seizures are every 2 to 4 to 6 months. So to record a seizure is rather difficult. And I suppose we could bring him into the hospital, stop all of his drugs and see what happens. And then see. And in fact, we were fortunate enough to show that the myoclonus is associated with bursts of generalized spike wave. And then the seizure begins with generalized spike wave. So we could confirm that it's, and again, juvenile myoclonic epilepsy with cortical myoclonus associated with spike wave burst. And in fact, on just a random ambulatory EEG, we saw myoclonus one morning with a spike wave jerk as well. So there are a number of options here, and yes? Consider adding phenobarbital. Would someone like to address that?
There's this very significant interaction between valproic acid and phenobarb, and you could easily make him unconscious.
Phenobarbital is probably not an ideal choice in this circumstance. It's probably a drug to be avoided, as would any other enzyme inducer.
Can you take
valproate inhibits phenobarb, but phenobarb also enhances valproate metabolism. Yeah, and you'll have problems.
No, I already talked.
Pass it back to Eva. Eva.
Ospolot sultiam sometimes helps to these guys
Sulfiam.
with the myoclone.
Yeah, so we don't have that. So there are a number of choices.
How are you so sure that he doesn't have progressive myoclonic epilepsy?
So how am I so sure he doesn't have progressive myoclonic epilepsy? He doesn't have myoclonus all the time. He just has scattered myoclonus, and he primarily has this myoclonus leading into a tonic-clonic seizure. He's got 4 hertz spike wave. He's intellectually normal. He just doesn't fit the clinical picture of a progressive myoclonus epilepsy, but it's a good thought. Is this a typical case, or are we dealing with something else? Manjari, you wanted to say?
Yeah, so about 5%, and in some series 10% of patients of generalized epilepsies, particularly the JMEs, would not respond to 1 or 2 drugs. I find zonisamide very useful, and I also find clobazam very useful in these patients. So I think we still have to explore at least 2 or 3 new drugs, and we've never given him more than 2 drugs. It would be worthwhile putting him on 3 with good doses and see what's happening before pulling off the second.
I don't think that I would actually advise this, but what about the ketogenic or perhaps even the modified Atkins diet?
Well, so in contrast to some of you, I have put teenagers and adults with normal intelligence on these diets, and they declare themselves pretty quickly whether they'll take it or not. But there's no data. So I think we have evidence for a lot of drugs that could still be tried. I must say my personal experience in this circumstance that I've never, at this point, added other things in and had people become completely seizure-free, that these are the type of problematic patients with drugs. And when they've had frequent tonic-clonic seizures, monthly or more, though perhaps it could be less, we have done calisotomy and published results of calisotomy in these cases with really very good results. I'll put a couple comments up about vagus nerve stimulation because this has been advocated from some people, and I'm not saying that I'm advocating or not, but there have been several reports. Doug Labar, back in 1999, published in VNS and generalized epilepsy. He had 3 cases of idiopathic generalized epilepsy, the bottom 3 cases, with generalized tonic-clonic, typical absence, and myoclonic seizures, and reported no real effect on the myoclonic, but response to the absence and generalized tonic-clonic. There's another paper that was published 10 years ago, Kostov and colleagues, 12 patients with idiopathic generalized epilepsy, one of the larger series in the literature, and they found a 62% reduction of tonic-clonic seizures, reduction of absence and myoclonus, And 2/3 of their patients, 8 out of 12, had a greater than 50% reduction, and 2 became seizure-free, they reported, and they reduced the average number of drugs from 2.3 to 1.7 per patient. And 2 patients were only on VNS, and they stopped all of the drugs and did well just on VNS, or as well or better than they had before VNS. So yeah, it's another option that we can consider. We put a lot of drugs. I'm not quite sure what's right for him. I think there are many valid treatment options. I would think that this is somebody I would not do brain surgery on. I would say that would be very much at the bottom of the list. But these are perhaps the more challenging patients that we have. Okay, what is this? So that with his arms. He's had neuropsychological testing. That's his appropriate testing in our patients. He stops and starts again. And it goes down. And then he does it again.
Hey Josh, remember the code word banana. Josh, can you touch your nose? Touch your nose, Winnie.
There's a little hint of
Josh,
not
can you point to
jerking
the
so much as
ceiling?
relaxing. He's not responding.
Yeah, can you start? I got stuff to the watch. That's good. Hey Josh, you okay? Yeah. Okay. Okay, want to suction you a little bit? Here, you might be able to swallow it now. Okay, want to do it for you? You just had a lot of spit coming out of your mouth, that's all.
So he had a lot of saliva, she said.
I can hear it. Yeah,
So I'm just going to go back, and I want you to watch what happens. He does that for 2 or 3 seconds, and then he stops. And then he does it again. And then he stops. And then he does it again.
Hey Josh, remember the code word banana.
So what is that? I would be not sure that it's not psychogenic. That's a lot of negatives. I would be not sure that I was not sure that you were not sure that it was not psychogenic. What's that?
Somatosensory reflex seizure by touching these triggering zones of his fingers maybe provoked seizures.
So how many think that this is epileptic? A few. Put your hands up quickly and put them down. How many thinks it's not epileptic? Fewer. Okay, so this is certainly epileptic. We recorded it with EEG, and it's very unusual, but that dystonic posturing, again, is a clue. That you don't see people with psychogenic seizures have such strange dystonic posturing. What's funny about it is he postures for a few seconds, then he stops, then he does it again and stops. And then when he held it, you saw brief relaxations intermittently, but it's epileptic. Can you tell what side it's from? And I don't think it's possible. This is actually, do we know what lobe it's from? Too much saliva, insula. Yeah, this was actually non-dominant frontal, but it probably spread to insula, producing that. So his hand is going towards his genitals at times.
Cohort Apple, can you tell me where we are? Can you clap your hands for me? It's all right. Alfred.
Yeah.
Can you clap your hands for me?
Yeah. Man, like that.
Where are we?
And he did not say where we were afterwards. Let's go back. Again, look at his face. See his face? And the hand goes then at his genitals. So are we all convinced this is epileptic now, right? I mean, I've been showing you epileptic seizure after epileptic seizure, right? So we're all convinced it's epileptic? How many think it's epileptic? How many think that I'm trying to lead you down a garden path? How many think it's not epileptic? Okay. So what did we see? We actually saw his right face pull tonically. And then we saw automatisms with the left hand. So this is coming from which hemisphere? Left. So this is the left hemisphere. The automatisms ipsilaterally, tonic, in this case from the face, contralaterally. And it was more right. He pulled up to the right. It was a right tonic facial pull in the left hand. But genital automatism, so where's this from? But cingulate and face. Okay. Yeah, so this is actually, this is a frontal seizure. It's a dominant frontal seizure, which is why he wasn't able to speak and follow commands afterwards. And it spreads into, I mean, it spreads widely, but you can see these genital automatisms with frontal lobe seizures, actually. It's been reported, genital automatisms. Is it spread orbitofrontally? Is it spread cingulate? I don't know. But this genital thing is a specific frontal lobe symptom. She's in it now. Note her hands.
Hi, Mary. I'm gonna give you a code word, strawberry.
Just rub your nose.
Hey, we're gonna keep this on, okay? Hey, Mary. We're gonna keep this on. You're okay, you're okay.
So do we all agree this is epileptic as well? Yeah, this is clearly epileptic. That you don't see psychogenic seizure patients do something like that. Where is this from? Left temporal. Why do you say left temporal?
She had automatisms, the right temporal. She had automatisms with the right hand. She rubbed her face with the right hand. And then she almost cried in the beginning of the seizure, which is an emotional diachristic component to it. So.
Well, I think she was still seizing. She was still seizing, although she could be postictal and confused at this point with automatic behavior. Yeah. So this, the vocalization though, yeah, the vocalization. So this was actually a non-dominant frontal lobe. This is a non-dominant. There's a theme today which is largely frontal lobe, other than the distal automatisms which were temporal. So this was a non-dominant frontal lobe, and she had a cortical dysplasia. We operated on her several years ago. She's been seizure-free, but the most interesting thing happened afterwards. You see what she looks like, how skinny she is. She's been seizure-free for about 3 years now. I saw her 2 or 3 months ago, and she must have put on 25 kilos in weight after surgery, with no change in her drugs or anything else. But a frontal, it was a prefrontal, and it was a fairly high parasagittal prefrontal focus that we did the resection with a cortical dysplasia. And I don't quite understand why, but why she comes in now and she weighs more than I do. So, that one last quick case and then we'll finish. 58-year-old right-handed man with seizures starting at age 15, one day after a momentary loss of consciousness with rapid head movement while playing football. And this is American football, where we try to break each other's bones rather than kick a ball around. He has complex partial seizures, focal seizures with impaired awareness, to use the present terminology, usually no aura, though sometimes he gets a funny feeling in front of his left ear. And then he speaks gibberish, which is a language spoken all over the world, and none of them can understand each other. And with loss of awareness, and it happens once every month or two. There's a remote history of years ago, when he was in his 20s, of having seizures that were secondarily generalized, or tonic-clonic seizures, one of which he saw a black hole, he remembers, that got larger, and then he passed out and shook. The others had no aura whatsoever. And he had one a year in his 20s and hasn't had any of these probably for 30 years. But he still has the complex partial seizures, focal impaired awareness seizures with typically no aura, other than occasionally this left feeling in front of his ear once or twice a month. He's now on lamotrigine 300 milligrams twice daily. It's a pyramid 100 twice a day, and primidone 250 milligrams per day. That's what I inherited. And he'd been on phenobarbital and phenytoin in the past. He's a college graduate, was a good student, went to Ivy League, but that doesn't mean anything. You know what the most favorable sign of getting into Ivy League is? To an Ivy League college? That's having a parent who went to an Ivy League college. That supposedly triples your rate of acceptance. But he was a good student. But now he's disabled from his seizures, can't drive. And on exam, he postures his left hand more than the right with stress gait. So for those who aren't familiar with stress gait, you have people walk on the outsides of their feet. And what you'll see is a posturing of one side. It's often a sign. And he postures the left side more than the right, for what it's worth. His neurologic exam is otherwise completely normal, including visual fields with, in fact, formal visual field testing. He'd been to an ophthalmologist who had done that. So what do we think this could be? Can anybody offer a localization, a suggestion, or diagnosis? And I think this history is fairly vague, right? We can say it's focal. You know, I don't know that we can say which side it's from, really. I said he had a black hole once with one seizure, but I don't think that provides us with much information. But here is his MRI. So would someone like to offer an interpretation of the MRI scan? What's that? So he has a dysplasia, where? By the red arrow, right?
Dysplasia and hippocampal signal increase in left hippocampus, I think, and dysplasia in the left parieto-occipital lobe, and visual manifestation may be typical for the occipital lesion.
Yeah, so this is, yeah, exactly. So spot on. He's got a left occipital dysplasia medially. It's interesting that he does not have visual auras now, and that he has a sensory aura, if anything.
Okay. I assume that you've got an arrow there, so people were convinced by it. But when you look at that MRI, there's an overall signal in homogeneity. The left hemisphere is generally brighter than the right hemisphere, at least on that particular slice. I assume that
Has a field in homogeneity, so the left hemisphere is always a little brighter than the right.
Okay.
It's a constant source of aggravation.
Okay. So, but you're convinced that this is, because the volume seems to be about the same. I mean, there doesn't seem to be any atrophy on that side.
I don't have T1, but in fact on T1 he has atrophy of the hippocampus and loss of internal architecture. But it's interesting that, you know, the 3T magnet that we use preferentially for epilepsy patients has a field in homogeneity, so the left side's always a little brighter than the right. And I don't feel so bad because I saw somebody recently from the Mayo Clinic who had her scan there, and they have a field in homogeneity, so that their scans are brighter on the right side. It always happens. Yeah. So this is really what could be considered a tandem lesion. And it's not that rare that occipital and temporal lobe epilepsy are linked together, that people with occipital lesions have coincident temporal lesions. You know, you couldn't really call this a focal cortical dysplasia type 3 because the dysplasia is outside of the temporal lobe. But nonetheless, you do have an ipsilateral occipital dysplasia here with the arrow, and this is abnormal there. And again, and this increased signal down at the bottom is very much artifact. We see that in a lot of our scans, unlike the hippocampus. So the interictal sharp waves are at F7, so they have anterior temporal interictal sharp waves, but it's interesting when I record seizures, and I'm not showing it to you, it's a very crisp occipital lobe onset, left occipital, 01, 12 hertz waves in some seizures, although others it's not so clear. So what management would you advise for this person? And again, this person has failed 5 or 6 drugs.
So, assuming that you can get away with it in terms of the neuropsychological tests, you could clearly consider, say, an amygdalo-hippocampectomy, because even though the lesion, even though the origin of the seizures is more posterior, it's conceivable that you could get a good, at least palliative result, assuming that the operation is neuropsychologically possible.
So even though we see ictal onset in the occipital, you would still say doing amygdalo-hippocampectomy because it may spread there and from there spread around and cause around. So that's one option. Anybody else?
I don't agree with you, Bill. So the option would be depth electrodes. Depth electrodes, intracerebral, to see whether it comes from hippocampus or from the lesion.
Well, it's the dominant hemisphere, and we're dealing with fibers close to the visual tracts. So definitely there seems to be 2 lesions. The outcomes for dual pathologies are best when both are removed, rather than leaving one behind. But one would like to look at propagation pathways. Before that, I would like to do a tractography to look at the visual pathways. I'd like to do a visual functional MRI, a language and memory. Oh, wow. RNS. I don't know if the RNS can go there. Yeah.
If the patient undergo MEG or EEG fMRI examination, if the patient have very frequent interictal epileptiform activity, MEG or EEG fMRI can help us sometimes to ospect ictal and interictal spect to decide where is the focus.
But I think we would all still wind up, if we were going to think about surgery, do SEEG first. The issue becomes that if that's primary visual cortex and that had to come out, you're going to make the person hemianopic, and then this person will not drive anyway, right? I mean, he can't drive because he's having a seizure every month or 2 now. You can make him hemianopic and seizure-free, and he still won't be able to drive. And then you've still left the medial temporal lobe in place. And in fact, with fMRI, he does not have much in the way of activation there with verbal memory, and he's got some verbal memory impairment, so I don't think you would hurt his verbal memory particularly. But I think that it's a challenging case. Bill certainly poses an interesting one of attempting to tackle that temporal lesion, and we actually can do it pretty minimally invasively with thermal ablation in our place, where you can take a probe and thermally ablate that hippocampus. You can show that you're probably not going to have much significant effect on memory, and that's a relatively modest way of attempting to help him. And if he doesn't get better with that, then maybe you call it a day, or you have to say that have to be willing to accept a hemianopia. And I don't know that anybody in advance know what it's like to live with a hemianopia.
Sorry, he's having 1 seizure a month? Every month or 2. So unless it's the cognitive problems, has some sort of rehab been attempted? You said that he was disabled by this.
His memory has gotten somewhat worse.
Okay.
And also, because of seizures, he can't drive. He's had seizures at work.
Okay, so
he was actually a college professor, and he had seizures in class. That was a problem.
So he was a legitimate Ivy League student.
His PhD was not from like mine. So these are challenging cases, and I don't know that there's a wrong answer or right answer. I personally like Bill's alternative, but in having a discussion, what do you pose the risk of benefit, or the chances of benefit? And I think we would have to say probably less than half, and potentially as a palliative procedure. And so you could consider RNS. The problem with RNS is that's a pretty big dysplasia. And if you were going to take one RNS electrode and put it in the temporal lobe, you've got a fairly sizable dysplasia there, and it's not clear where you would put the RNS in that area. So, arguably, if you wanted to be aggressive, you would ablate the hippocampus on the left, and then you could put 2 electrodes in that dysplasia and maybe help them a little bit more. Yvonne?
It depends really on the functional properties of the tissue around the dysplasia, because sometimes we can achieve a partial effect by diminishing the size of the dysplasia, saving the primary cortex. We saw such patients, and so they are not completely seizure-free, but they have a seizure in 6 months or so by having leaving just a small strip, and so.
But again, it's a concern operating in that area that the worst of all possible worlds is you give him a hemianopsia and he still has seizures, right? Not to touch the primary. Yeah, but it looks like this is primary cortex to us, actually. But not only. Outside, it's very large, yes. Yeah. Yeah, yeah. Yeah. So I discussed a number of these various options with him, made it clear that I was not terribly enthusiastic that we were going to cure him, that the odds were relatively small. And I led him down the path a little bit. I told him the options, but I made it sound as though that maybe surgery is not the best thing for you. And he after a discussion, saying that I think the odds of curing you are probably relatively small, and given the risks, the option was to continue with other medical therapy. I mean, he hadn't had that many drugs, and this is one of those where I think we would try more drugs and try to make things better rather than hurt him. I was reasonably convinced we could hurt him with surgery. I was not nearly so convinced that we could help him. And yes, Amos. Can I tell you, I don't know much more about other than.
When do you do it?
I do it in everyone. If they're if I know that they have a scan that's normal in advance, but the stress gate, if it's lateralized, does give a clue as to pyramidal dysfunction contralaterally. It doesn't necessarily indicate a focus in the frontal lobe, but it suggests that it's an abnormal hemisphere, and it's a weak, helpful lateralizing sign.
So it is a lateralizing sign unrelated to seizures, to epilepsy.
Oh yes, it's unrelated to epilepsy. Yes. You can see it in children with developmental problems and autism, for example, and other things. It's not specific for seizures, but if it's lateralized, it can be helpful. I would say, in my experience, probably close to half the time it's bilateral when you have kids who have problems. So it's not that helpful, but it's a clue that something else is going on. And I'm reasonably convinced that we're finished. Yes, we are. Thank you all.